It is not possible to provide care at 75 shillings, surely. When you are taxing Kenyans at 2.75%, when we know that the average premium is now 900 shillings for the informal sector.
We need to do a lot of work, especially the efficiency aspects at the two authorities, the Social Health Authority and the Digital Health Authority.
Hello ladies and gentlemen, welcome back to the backstory. If you are new here, kindly hit the subscribe button and the notification bell down below so that you can be notified whenever we post a new video. Now ladies and gentlemen, there is a health crisis that is looming in the country after more than 600 hospitals that are affiliated to the Rural and Urban Private Hospital Association in Kenya, also known as RUFA, suspended all socio health services in their facilities, that is starting from today.
Mfumo ambao umepatiano katika mahospitali wa global budget capitation tumeiangalia na tukaona kwamba haiwezekani kupeana huduma za afya kutumia mfumo huo. Mfumo huo ambao unatoa shilingi 900 kwa kila member kwa mwaka, ambayo ukihesabu ni chini ya shilingi 75 kwa mwezi.
We must have a complete closure of the issue of NHIF arrears. On the issue of outpatient reimbursement mechanism, it is not possible to provide care at 75 shillings, surely. When you are taxing Kenyans at 2.75%, when we know that the average premium is now 900 shillings for the informal sector, how do you explain paying 75 shillings for a diabetic patient, a hypertensive patient? We know that our dialysis centers are collapsing under the burden of NHIF claims. It will be tragic that from Monday you would expect dialysis patients to start going back to their pockets. This is not the situation we've wanted. We want to protect the sector. So two very important things. One, there must be a clear commitment and a clear plan to settle NHIF arrears.
Now, RUPA is claiming that they are owed more than 30 billion in arrears from the National Health Insurance Fund, NHIF, with the debts dating from 2017 to the time of transition. Remember, NHIF transitioned into SHA in October last year. That is like around 4 months down the line. And the transition has not been very smooth. The officials are claiming that the government has not been responsive to some of their complaints. They've tried to engage the government, and the government has not been responsive. So some of the most significant issues that have been raised about SHA, because so many Kenyans have come out to raise complaints against SHA. And some of the issues that have been very significant include the prolonged system downtime, delays in OTP, that is one-time password verification, and then the inability to track claims approval by SHA to the service providers. So we want to look at some of these teething issues. One is the prolonged system downtime. So in system downtime, it means that whenever you log into the SHA, it takes like forever to activate so that you're able to access services. So service providers, when you go to the hospital, they log into the system, key in password, and if the system is working, they are supposed to now get all your information on their laptop or on their software so that they're able to key in. The doctor is able to write, or they're able to inform SHA that there's a patient that has come in, and these are some of the things that we are going to, these are some of the services that we are going to provide. They're able to track and see like how much is provided for you under whatever service they are going to provide, so that they're able to know how much they're going to allocate to consultation, how much they're going to allocate to Medicare, laboratory, and all that. But whenever these service providers log in, it takes time for the password to be accepted so that they can log into the system and see all this. So that is one prolonged system downtime. Then there is the delays in one-time password, OTP verification. This is whereby when you go to the hospital, once they've logged into the system and you are a registered member of SHA, there is what we call password, OTP password, whereby you send a unique number. Once they've logged in, they log into they key in your phone number into the system. Then the system generates a unique password that is sent to your phone. This will enable them to know if you are the authorized member who is supposed to access services. So that password is sent to your number. It's a unique code. It's sent to your number. Then you're able to read that number to the service provider. They key it in, and then they are allowed to access your information. So that has also been causing delays. And remember, once this delay is realized, it means that it will take time for them to provide services to you. The other issue that has also been creating a lot of problem is the inability to track claims. So let's say, for example, they are successful to do all that, log into your system and provide services to you as a patient. At the end of the day, since you've not paid cash, at the end of the day, these hospitals should be able to now make claims. They are able to send them like whatever amount they've charged for all the services that they've provided for you. They're able to send that claim to SHA, so that SHA will, according to the agreements, are supposed to pay them if it's on a monthly basis or after every 2 weeks, whichever the agreement. So the finance department is supposed to now make claims, and then they are able to track how those claims, where they are, if they are going to be paid. They're able to see, and this enables the hospitals now it helps the hospitals now to do their day-to-day running activities. So if these are not being honored, then one thing that happens is the fact that hospitals now are unable to operate. Because take, for example, a situation whereby they've provided services to you, and then SHA is unable to pay them. How do you expect all these people, all these hospitals, to operate? One, at times they take loans so as to provide services to you. Then if these services are not paid for, it means they will default. When they default, banks will be on their neck. Then secondly, the other issue will be that once they don't have money, they cannot provide services to patients. They will not get specialists, doctors to provide services. And then the end result is the quality of service that is provided, or quality of healthcare that is provided to patients will reduce, because all these specialists will now look for hospitals that are paying better, and the quality of healthcare will be compromised at the end of it. But you ask yourself, why is it that SHA is not working when guys are paying a lot of money in terms of contributions? The guys who are employed are paying 2.5% of their salaries, which in essence should give enhanced contribution compared to NHIF. But why is SHA not working? There are claims by some people that SHA is being sabotaged so that private hospitals or the current providers can close down, and then some people can take over. I don't know if that is true, but if that is the case, then that is a very, very unfortunate situation for this country. But Another issue that might contribute to this is the fact that, you know, when SHA was came into being, that is in October, the president was quoted as telling Kenyans that he was targeting the employed, so that out of the money generated from those who are employed, he could use that money to now pay for the unsalaried. That argument then made a lot of sense, but look at it. How many people are employed in this country? And how many people are unsalaried? Take, for example, a situation whereby we have like around 2-point-something million people who are unemployed. But those who have registered in SHA are close to 20 million. So you are using money contributed by 2 million people to carry the burden of over 20 million Kenyans. That is unrealistic, because it is the president who told all these people that he is going to pay, the government was going to pay for them. So at the end of it, Kenyans are sitting back and waiting for services as had been promised by the president. You know, the difference between SHA and NHIF, and Kenyans will bear me witness. NHIF was working, even though it had like teething problems, some problems here and there, but we needed to have tightened some of the loopholes that were in the NHIF system and made it better. And even if we were to transition from NHIF to SHA, we should have given ourselves like 1 year to pilot, to try and see some of the issues, some of the problems, because transition from one system to another takes time. It should be something which is gradual. But our transition was immediate, and we expected it to happen. We expected it to work seamlessly. That has never happened. We needed to have given ourselves time to look at some of the teething problems in SHA, iron them out, and then unveil it. But because, you know, you cannot experiment with the lives of Kenyans. You cannot experiment with the lives of people. There are guys who are in serious conditions whereby if they don't get services there and then that is a life lost. Look at what the officials were talking about. Reduced tariffs for specific conditions, like let's take, for example, dialysis. It's being claimed that the tariff for dialysis has been reduced. What does that mean? It means that Kenyans will have to go back to their pockets in order to access these services. Already, Kenyans are constrained because of the current financial situations of Kenyans. So how many people can sustain the out-of-pocket payments? How many people can pay for Medicare on a cash basis? That is why the government needs to work hard so that SHA works. But it can only work if there are no hidden agenda, no hidden interest whereby people are willing to compromise on the quality of healthcare and on the lives of other people so as to make money out of it. Because SHA should have been working. It should have been made in a way that it works for the people. Remember, Kenyans were really struggling to pay even the 500 shillings during NHIF. But they've enhanced it in such a way that the Kenyans who are in the informal sector are currently paying around 900 shillings, even though we were told they were going to pay 300. But I've talked to guys are paying 900 shillings. So if someone was unable to pay 500 shillings on a regular basis, how do you expect this person to pay 900 shillings? There are cases whereby Kenyans would wait until they are befallen or they are sick, that is when they would pay, they'd look for money to pay for the 500 shillings or clear like a balance of arrears of like for 1 year, that is 6,000. Then they access Medicare. Then thereafter, they'll forget about it. So the government should look for a way that they are going to capture the majority of Kenyans who are not willing or who are unable to pay for this. Why don't we reduce it to maybe 300 shillings so that we capture so many people within the system and we are able to provide services to them. So ladies and gentlemen, that is it from us today. If you're new here, kindly hit the subscribe button and the notification bell down below so that you can be notified whenever we post a new video. Until next time, bye bye.